So next talk will be by Dr. Girija. She'll be talking on the management of normal tension glaucoma.
So, very good morning to everyone. Management of normal tension glaucoma. So, whenever the patient comes with you, comes to you with a normal intraocular pressure, but other features like large cup with a thin neuroretinal rim, you are always doubtful whether is this glaucoma or not. Even if the fields show some changes, you cannot start treatment unless you are very sure, because it's a lifelong treatment. So this normal tension glaucoma presents in a very similar manner just as a primary open angle glaucoma, except that the intraocular pressure is always below 21 millimeters of mercury. And always you should, when you are deciding on treatment, you should think about the risk factors, because whether it is normal tension glaucoma or not, you have to be sure. So it's more common in females, older people, and you have to take because the IOP is normal, you have to take a diurnal variation. A facing should be done, and a 24-hour facing is always better, because NTG is associated with nocturnal spikes, which you will not get if you do a office hour facing. And the other vascular conditions like Raynaud's phenomenon, migraine, all are risk factors. You get more incidence of NTG. And the cardiovascular dysregulation factors and other acute ischemic episodes and obstructive sleep apnea syndrome, all these should be kept in your mind when you are thinking about the diagnosis. This 50-year-old male came to us for an RTA management. He had a rupture globe in one eye. The right eye was lost following that. During that examination, we found that the left eye was having a large cup, a 0.8 cup with bipolar notching. And this was in 2019. So he was started on prostaglandin analogs, and he was followed up. And the IOP came down to 10 to 12 millimeter range. But he was on regular follow-up. In 2021, we noticed that the fields are progressing. And since it's one-eyed, we were doubly careful, and we started dorsalamide, which gave an AT of 8 to 9 millimeters. Yeah, even then, the disease was progressing. 2022 HFA also showed progression. So the patient was advised trabeculectomy because he is one-eyed and the disease was definitely progressing, but he was not very keen, and hence we added a third drug. In 2023, he had another RTA. The first admission was for an accident, and this one also another RTA. But he came again for follow-up after that, and he admitted history of dosing of while driving. And the wife complained about snoring at night. So because of this repeated accidents, we were also doubtful of a obstructive sleep apnea syndrome, and we sent him to a sleep clinic, and sleep study was done, and it revealed a moderate to severe OSAS, and he was put on CPAP, and the sleep has improved now, but his next field is yet to be taken. So IOP independent risk factors like this has to be thought of when you are thinking about the management and the investigations, because you don't have to do all the investigations in all the patients, but take a careful history about all these risk factors like trauma, inflammation, severe blood loss or hypotensive events, except especially severe blood loss can lead to a single acute episode, but it will not progress. So such history only can reveal such things. So diagnosis can be made. So comprehensive eye examination, including gonioscopy, the regular comprehensive eye examination has to be done with all the routine investigations like HFA and OCT. And these are the usual features of a NTG, less than 21 millimeter IOP, the characteristic cupping, large disc, large cup, dense, more focal and closer to fixation field defects or scotomas, especially which occur early in the disease. So this patient, a 59-year-old male, came with blurring of vision left eye in 2021, and his corrected vision was 6.6. The IOP was normal and the CCT was slightly on the thinner side, but the fundus showed a 0.8 cupping in the right eye with superior and inferior notching, and left eye showed a 0.9 cupping with the superior and inferior notching, and there was corresponding field defects in the eye with the OCT appearance. And he was started on prostaglandin analogs, latanoprost, and he was Then he went abroad and he was lost for follow-up for 2 years. Then he came back in 2023, and in the meantime, he consulted elsewhere, has taken a HFA which showed some progression of left fields, and he was advised, I think, stepping up of treatment, and he came to us. The IOP on examination was 14 millimeters of mercury, and a detailed history revealed that he was detected as a hypertensive in the 2-year period, and he was started on a systemic beta blocker. So we did the phasing, and there was a nocturnal there was wide fluctuation in the IOP reading, and we sent him for a cardiology consultation, and the 24-hour BP monitoring we requested actually, and that was done, and it showed a nocturnal dip, and the night dose is changed now. I think they changed the antihypertensive. So unless you take a proper history, you will not know about this. So 24-hour blood pressure monitoring is not done in all NTG patients. So sleep studies are not required in all patients. So only if you take a proper history, you will know what to do. And MRI is another thing. When a young patient comes to you with a large cup, especially if cupping is in excess of pallor, then you have to think about a neurological cause. You take a visual field, and if the visual field is something like this, a vertically aligned visual field defect, then again you have to think about a neurological evaluation. Similarly, color vision deficits in the absence of visual field defects or marked asymmetry of unilateral optic nerve involvement, again you have to think about a neurological evaluation. A 58-year-old female came for checkup, and the fundus showed a 0.65 to 0.7 cupping in the right eye with inferior NRR thinning and inferior RNFLD. And the left eye also had inferior polar notching and inferior RNFLD, and the IOP was in the normal range, normal CCT, but you can see that there is superior arcuate scotoma in both the eyes, and the left eye is showing a paracentral scotoma. So whether to start treatment or not, but because it was not a consistent thing, the disc and the fields were not compatible. So we repeated the visual field some 2-3 times, but it was consistent. So the patient was started on PGA. The IOP was 9 to 10 millimeters of mercury, and the visual fields on follow-up remained status quo in 4 years. So now we are in a dilemma. This is something again we all face, whether to stop the treatment, change the anti-AGM, or to continue. So here it was solved by the family history, because the mother has glaucoma, we have continued treatment, but again you have to individualize treatment. You cannot say that you have to continue in all cases, but you have to individualize the cases and evaluate and decide. So the treatment is, that natural history does not always include progression without treatment, and in CNTGS, 65% of the eyes without treatment showed no progression, and 30% reduction in the IOP has reduced the risk of progression from 35 to 12%. But always monitor the patient without treatment. That should be the suitable initial strategy in many cases. But always discuss with the patient pros and cons of starting a treatment, and it will be lifelong. And progression is usually at a high risk in females, those with a history of migraine, optic disc hemorrhages, greater variations in the diurnal IOP, etc. But it is slower than in a POAG. So you can take time and decide. And exercise and meditation is said to have a positive effect on IOP reduction. So what drug to give in such cases? So medication should be chosen on an individual basis, and the effect of medication on systemic blood pressure, heart rate, and other optic nerve perfusion should be always considered. And the prostaglandin analogs are the single most effective agent in reducing it, because it has adequate diurnal control. Beta blockers, but they don't have that much nocturnal IOP control. And the other drugs, again, topical alpha agonists supposed to have a neuroprotective action, though it is not proven in humans. Then topical carbonic anhydrase inhibitors, again they are supposed to improve the ocular blood flow. So all these agents you can try depending on the risk. So all the risk factors you think about. So laser trabeculoplasty, especially the SLT, now it is giving some promise to this management of NTG. MIGS with cataract surgery, that is again either with cataract surgery or as a standalone procedure, that results in modest reduction in the IOP, but it can reduce the medication burden, and it can actually delay the trabeculectomy. But usually the target IOP here is less than 10 millimeter, and trabeculectomy is the most effective method of achieving low intraocular pressures, and it can blunt diurnal and nocturnal IOP progression. And GDDs are usually, it is not the first choice. Trabeculectomy is a more suitable surgical option. And the new IOP independent neuroprotective therapies like memantine, uniprostone, brimonidine even, that's supposed to have neuroprotective action. All these agents, calcium channel blockers, statins, all these are supposed to have some neuroprotective action. That is under research only. And stem cell therapy is the latest one, which can regenerate retinal ganglion cells and produce new cells. And actually, RGCs are the ideal target for stem cell therapy because they have the benefit of being confined to the intraocular space and may be less likely to be affected, but it has to be carefully monitored because of the risk of tumor formation. And this is under research. Probably that will give us a promising treatment. So the take home message is, it is a diagnosis of exclusion. Always consider the risk factors, get a thorough detailed history, do a careful examination, and do neurological investigation only in indicated cases, and before starting treatment always discuss with the patient. Thank you.
Thank you, ma'am. Thank you for that detailed talk with the case scenarios. The next talk is on management of ocular surface disorders due to anti-glaucoma medications by Dr. Vinay. Over to you, sir.